Hello and welcome to this episode of Let's Talk, where we zoom in on the practical implications and the next steps of some of the big sessions here in the Milan Congress. And in this episode, we are going to talk about when to go digital and when to go analog. My name is Gerrit Heijkoop and I'm very happy and to be proud to be joined by the two chairs of this session on stage. Óscar González Martín from Spain. Óscar, welcome.
Thank you so much.
And also with me, Carlo Monaco from Italy. Carlo, welcome.
Thank you so much.
Welcome. You just come from the stage with three exciting speakers. But first, let's start with the basics. This is the 2024 Congress. Why are we even still talking about the question when to go digital, when to stay analog? I thought we were fully digital already.
Well, this is a great question, and thank you for having us here. I think we have just seen an amazing session where we realize that we are still in the middle of I would not say nowhere. I think we know where we are going to, where we're heading to. But still, we are in the world where there is no pure digital workflows for every single scenario. And although in the last, I will say 5-6 years, we can clearly see that we are moving somewhere with a clear direction, which was not the case a few years ago. I think we are still in the daily practice mixing protocols. So we start here and then we move to digital and then we move to analog. I think after the session, we may still have the feeling, and I don't know what Carlo feel, that we still have the feeling that we are there. We are closer to move, especially in certain protocols, from a full digital, but we are not fully there.
All right, let's explore where the analog is still the golden standard and where the new opportunities arrive. In your session, Carlo, you took three different perspectives with your three different speakers. We took the surgery perspective, the restorative perspective, and the lab perspective.
Exactly.
Which perspective was most surprising to you?
Yeah, it's a laboratory perspective because the digital start in the laboratory section, and the first at first time the dental technicians start with the digital because the story of digital technology started with the zirconia restoration. Zirconia material is the only material that can be worked only with digital technologies, and then the dental introduced the digital technologies inside, and then the digital technologies move to the office, to the dental office with the digital impression, and now the digital impression is a traditional impression that we take. But when you send the digital impression to the dental laboratory, we can have some problem in the daily practice. And
what type of problems?
Yeah, the problem because the quality of the quality of the impression is very high, but the quality of the gypsum model or the 3D printed model are different. Mm-hmm. This is the reason why we discuss with the dental technician about the quality of the precision or the high, very level of quality of the digital and traditional model. And we start with digital impression, but in some case, in a steady case, we need to come back to traditional impression or come back to traditional materials.
So you say specifically in the static zone, yeah, Óscar.
It's very interesting because this Congress name is Details Made Perfection. And the difference is about details. Mm-hmm. What that was Carlo just mentioned is about the precision. We are putting together two worlds, the digital, but also the minimally invasive dentistry.
Yeah, right.
Aha.
So
tell me more.
The thing is, we are in the middle of these two mainstream philosophies.
But digital, I understand. I understand what you say about the variability, because obviously, when I take a digital impression, I make a model of a real-world patient. The model might have micro variations, and based on the model, I create a prosthetic that might have micro variations, so I can see how that adds up. Yeah. But now you add precision.
Yeah, precision.
What is that?
With minimally invasive dentistry. Yeah. But when we are working in this minimal thickness veneers, we are talking about to push the tissue with the implant prosthesis 0.5 millimeter up because you want to hold the zenith of the gingiva. all these minor details where we have just seen and what we feel in our clinical practice, this minor refinement has to go analog. So
because it's too sensitive, the error margin is bigger than the
Actually, for the people who is gonna watch this session, Giuseppe Romeo, one of the speakers, he mentioned when you work with the stone, you feel. When you are in front of the computer, you don't feel any pressure. You just move your mouse up and down, and there is no feeling over there. And this is a difficult learning experience, learning curve. And of course, I understand that all this new generation that they were born digital, I'm quite sure that in a few years they will more refine than what we are today. And we cannot lose the analogical, the feeling, the clinical, the touch. We cannot lose that.
It's an interesting perspective, because I can imagine if we go into the micrometers or nanometers even, like for example, when you produce microchips,
sure,
it's all digital and machinery. So now the dentists are saying, wait a second, if we come really to the details, back to analog, but we make a motion of the hand, but analog is not a hand per se, right? What does it mean? When to go analog, and what does that look like?
Yeah, we can divide in aesthetic zone or in implant restoration. Right?
Okay.
When we prepare the restoration for the aesthetic zone, we need to go to the analog in some situation to feel the details. But the same details are are important, but not in micron details that we can find in the digital when we use the implant restoration, and we can use in the digital technologies when we put an implant or prepare or planning the implant, and when we use a traditional technology, more sensitive when we choose the aesthetic restoration in anterior area. But aesthetic restoration, not only implant, aesthetic restoration for laminate veneer or something like that.
Exactly. But help me understand, where are we in the treatment protocol with the feeling? Are we talking during surgery, implant placement, or is it purely by when creating the prosthetic? Where is this feel needed?
Well, that's an interesting question. I think in the surgical field, we have created some protocols that work quite nicely for a large number of cases. Of course, there is a lot of science behind. There is a lot of even economical effort for the companies also to help us to create those protocols: guided surgery, guided planning, the surgical planning, improvement in the radiology. I mean, there is a number of things that we have been seeing in the last maybe 20, 25 years. And today I will say that you can plan the position of an implant in a very accurate way. And of course, as you will see also from Gustavo Avila, from the lecture, he also pointed out that there is a number of situations where you cannot go fully digital because you have to compensate for bone, or you have to compensate for soft tissues, or you have to do few things where you have to still do some analogical steps. When we talk about prosthesis, there is a large number of situations, especially in the posterior part of the mouth, where you can go, in that sense, you can go digital. We have this great lecture from Lucas. There was an amazing lecture, and he divided in 3 different scenarios: the single crown, the partially edentulous, and the full restoration. And he mentioned quite clearly what are the limitations or what are the advantages of each of them. And there is a number of situations where you can go fully digital, but there is a number of situations that still we need the human touch. And this human touch, I think, it makes the difference still with certain number of restorations.
Exactly. And so it matters clearly aesthetic zone. If it's not perfect or the details are not in the perfection, it's well, an aesthetic failure could be a failed outcome, right? While in the posterior region, it might be less of
we can be a little bit less critical.
But in aesthetic zone, we need to divide two types of restoration, because when we work on implants, the digital technologies help us to copy the shape of the soft tissue. And that this is very difficult to do in a traditional way. But when we do a laminar veneer, it's a completely different situation. This is the reason why we have to understand that digital is perfect to copy, to superimpose more impression, and that it's impossible to do with the traditional impression. But at the moment, probably in the future will be different, but at the moment, some details feel different than the analog.
Exactly. So it's clear. So it's not a black and white situation. It is understanding the patient. I'm still a little bit curious about, Óscar, when you mentioned the minimal invasive dentistry. It's a new term. It's an interesting term. What are we trying to achieve? Is it less surgical steps? Is it smaller or less impactful? What does it mean, this term?
It's all of that.
All of that.
Actually, is try to be, I would say, less invasive, less aggressive with the way we prepare teeth, for example, the way we do our surgeries with flaps that they are as minimal as possible, as big as we need to. I mean, when we do surgeries, we need to open flaps and we have to work with, but also there is a number of situations where people is doing flapless approaches, going to less invasiveness of the treatment. So
because obviously I'm not a surgeon myself, but I learned now also from our conversation earlier that a flap approach is probably has a better aesthetic outcome, but is more invasive for the patient. Is that what you're saying?
No, absolutely not. I will not say that is more aesthetic or has a better result, because it depends on the case. I mean, in an immediate implant placement, we try to do not raise a flap. So there is a number of situations, and the most important part is each situation has its own treatment, and there is not always a one correct one. So we have to really do a clinical adjustment at what we need to do in every single case. While we were having the conversation, it came to my mind a different term that it was not part of this specific session, but now it came to my mind that we are in the middle of the time of the artificial intelligence, which is not the same as digital.
No.
So I think now artificial intelligence is going to also help us to develop some digital protocols. So that's why we're in the beginning of facing a new era that we haven't finished the era before, and we're facing the new one. So I think I'm getting old for the new one, but I'll try to do my best.
Yeah, so the artificial intelligence is an area that I do a little bit more about. And I see the link with digital, because AI can only work when there's data.
Exactly.
And when the dentistry is moving from analog to digital, there's so much more data on the specific patient, but I guess also on the whole body of potential patients.
The next
I can add that the new era will be in the future with the material that will be produced with the 3D printed, and it's probably in the future our dental technician cannot produce laminate or a single crown or bridge directly with CAD/CAM system or directly manually, but they can print, and we don't know exactly where we will arrive, but probably in the future, the dental technologists will introduce the 3D printer for the production of materials. It's very artificial intelligence, new technologies, and the new materials combined together will change the future of dentistry.
You bring a very important topic, which is it's only work if we have data. Where is this data coming from? You need to have the right data.
And if you train the AI on the wrong data, or if you model, or you come with a poor impression.
That's my point. The right data is coming for experience, for knowledge, for research. So even we're heading this particular era, we cannot forget the classical concepts of treating a patient.
Absolutely.
We cannot forget that we are not treating machines.
Exactly.
We're treating someone that have a certain situation, that have a certain characteristics, and is experienced as a clinician. The one is going to create that data, and from there we can facilitate the long term or the develop of those artificial intelligence and digital protocols.
And remember, the skill and experience is also necessary to actually be able to judge whether a proposed AI solution makes sense. Because AI can think of anything.
Absolutely.
Now, to round up, you say feel is still necessary. The title of the session is When to Go Analog. If we look to next week and the participants in your sessions or the viewers of this session go back to their clinic, what do you hope the change that they bring into their own clinics as of this session? What do you hope they do?
Yeah, the people can use the digital to plan. It's very important to plan the position of the implant.
That's a no-brainer.
Yeah.
Right? If you're not yet digital in that phase, move in.
Moving directly to the plan. When you take the impression, you can use digital, okay? But when you do a very aesthetic case on minimal invasive preparation, you can think and talk with the dental laboratory to choose the workflow, the correct workflow. This is very important because often the new guys take the impression digital and don't know what happened in the dental laboratory. To talk with the dental technician about the specific clinical case, decide which is the best way, digital to analog, and decide together for the patient, to finalize in an excellent way the case.
Exactly. So you're asking for an extra meeting, extra time in the agenda.
Absolutely.
In these cases, call your technicians, sit together and decide together on the appropriate approach.
Yes, plan the case before, not only for plan the position of the implant, but plan the restoration, completely planning the restoration and decide which is the best way to choose.
Carlo, do you think this can be a digital meeting though?
Yeah, digital.
So the meeting can be digital as long as you decide on the approach. Nice, thank you. Óscar, for you, what do you hope people really do differently after this session?
I think it was a very honest session. I think I will not... My message will be keep an eye on what's going on. Keep learning. Keep getting yourself prepared for what is coming. Lead what is coming, because it was a lot of bright minds that I could see in this session that, of course, they will lead what's going on in the next few years. Of course, I fully agree with everything Carlo just mentioned, but my message will be pretty much, do not forget that we're treating patients. Do not forget that, in my opinion, still digital is just a tool. It's just a tool. So the knowledge has to be there. And of course, if we can make our life easier, be more precise, we shorten in time, and make the life of the patient better, that's great. But based on a solid knowledge of the classical concept of what it means to treat a patient, and from there, I mean, you can reach the sky.
Exactly. Well, that's a strong message. Thank you very much, Óscar. Thank you, Carlo. And I guess you must be just as curious as I am now about this session with the three speakers, Gustavo Avila, Lucas Waltenberg from Germany, and Giuseppe Romeo. So check it out on the Milan Library online and go educate yourself based on science.